Hi everyone. Welcome to Journal Watch with MJ.
A quick comprehensive review of the important and interesting articles published over the last fortnight.
Our first article for today is Cardiac Myosin Activation with Omecamtiv Mecarbil in Systolic Heart Failure, GALACTIC HF Trial. Background of this study is that the selected cardiac myosin activator Omecamtiv Mecarbil has been shown to improve cardiac function in patients with heart failure with a reduced ejection fraction. Its effect on cardiovascular outcomes is unknown. Coming to the methods, they randomly assigned 8,256 patients, inpatients and outpatients with symptomatic chronic heart failure and an ejection fraction of 35% or less to receive Omecamtiv Mecarbil, doses of 25 mg, 37.5 mg, or 50 mg twice daily or placebo, in addition to standard heart failure therapy. The primary outcome was a composite of a first heart failure event, which includes hospitalization or urgent visit for heart failure, or death from cardiovascular causes. Regarding the results, during a median of 21.8 months, a primary outcome event occurred in 1,523 of 4,120 patients, that is 37.0%, in the Omecamtiv Mecarbil group, and in 1,607 of 4,112 patients, that is 39.1% in the placebo group, with hazard ratio 0.92, 95% confidence interval 0.86 to 0.99, and a p-value of 0.03. A total of 808 patients, 19.6%, and 798 patients, 19.4%, respectively, died from cardiovascular causes with a hazard ratio of 1.01 with 95% confidence interval of 0.92 to 1.11. There was no significant difference between groups in the change from baseline on the Kansas City Cardiomyopathy Questionnaire Total Symptom Score. Conclusion: the authors concluded that among patients with heart failure and a reduced ejection, those who received Omecamtiv Mecarbil had a lower incidence of a composite of a heart failure event or death from cardiovascular causes than those who received placebo.
Interesting. The next article we have for today is Convalescent plasma antibody levels and the risk of death from COVID-19. The background of the study is convalescent plasma has been widely used to treat coronavirus disease 2019 under the presumption that such plasma contains potentially therapeutic antibodies to SARS-CoV-2, which can be passively transferred to the plasma of the recipient. Whether convalescent plasma with high antibody levels rather than low antibody levels is associated with a lower risk of death is unknown. Coming to the methods, they did a retrospective study based on a U.S. National Registry, where they determined the anti-SARS-CoV-2 IgG antibody levels in convalescent plasma that are used to treat hospitalized adults with COVID-19. The primary outcome was death within 30 days after plasma transfusion. Patients who were enrolled through July 4, 2020, and for whom data on anti-SARS-CoV-2 antibody levels in plasma transfusions and on 30-day mortality were available were included in the analysis. Regarding the results, of the 3,082 patients included in this analysis, death within 30 days after plasma transfusion occurred in 115 of 515 patients, that is 22.3% in the high titer group, 549 of 2,006 patients, that is 27.4% in the medium titer group, and 166 of 561 patients, that is 29.6% in the low titer group. The association of anti-SARS-CoV-2 antibody levels with the risk of death from COVID-19 was moderated by mechanical ventilation status. A lower risk of death within 30 days in the high titer group than in the low titer group was observed among patients who had not received mechanical ventilation before transfusion. Relative risk, 0.66. 95% confidence interval, 0.48 to 0.91. And no effect on the risk of death was observed among patients who had received mechanical ventilation. Relative risk, 1.02. 95% CI. 0.78 to 1.32. The authors conclude that among the patients hospitalized with COVID-19 who were not receiving mechanical ventilation, Transfusion of plasma with higher anti-SARS-CoV-2 IgG antibody levels was associated with a lower risk of death than transfusion of plasma with lower antibody levels.
Nice, Jenny, thanks. The next article we have is inhaled treprostinil in pulmonary hypertension due to interstitial lung disease. The background of this study is that no therapies are currently approved for the treatment of pulmonary hypertension in patients with interstitial lung disease. The safety and efficacy of inhaled treprostinil for patients with this condition are unclear. Methods: patients with interstitial lung disease and pulmonary hypertension, documented by right heart catheterization, were enrolled in a multi-center, randomized, double-blind, placebo-controlled, 16-week trial. Patients were assigned in a 1:1 ratio to receive inhaled treprostinil, administered by means of an ultrasonic, pulse delivery nebulizer and up to 12 breaths, total of 72 microgram 4 times daily, or placebo. The primary efficacy endpoint was the difference between the two groups in the change in peak 6-minute walk distance from baseline to week 16. Secondary endpoints included a change in N-terminal pro-B-type natriuretic peptide, NT-proBNP level at week 16 and the time to clinical worsening. Regarding the results, a total of 326 patients underwent randomization, with 163 assigned to inhaled treprostinil and 163 to placebo. Baseline characteristics were similar in the two groups. At week 16, the least squares mean difference between the treprostinil group and the placebo group in the change from baseline in the 6-minute walk distance was 31.12 meters, 95% confidence interval, CI, 16.85 to 45.39, p less than 0.001. There was a reduction of 15% in NT-proBNP levels from baseline with inhaled treprostinil as compared with an increase of 46% with placebo. Treatment ratio 0.58, 95% CI, 0.47 to 0.72, p less than 0.001. Clinical worsening occurred in 37 patients, that is 22.7% in the treprostinil group as compared with 54 patients, that is 33.1% in the placebo group. Hazard ratio 0.61, 95% confidence interval 0.40 to 0.92 with a p-value of 0.04 by the log rank test. The most frequently reported adverse events were cough, headache, dyspnea, dizziness, nausea, fatigue, and diarrhea. Conclusions: in patients with pulmonary hypertension due to interstitial lung disease, inhaled treprostinil improved exercise capacity from baseline, assessed with the use of a 6-minute walk test, as compared with placebo.
Thanks, Maverick. The next article is effect of oral Moxifloxacin versus intravenous Ertapenem plus oral Levofloxacin for treatment of uncomplicated acute appendicitis. The APPAC2 randomized clinical trial. The objective of this study is to compare oral antibiotics with 36 combined intravenous followed by oral antibiotics in the management of computed tomography confirmed uncomplicated acute appendicitis. Regarding the design, APPAC2 is a multi-center, open-label, non-inferiority randomized clinical trial was conducted from April 2017 until November 2018 in 9 Finnish hospitals. A total of 599 patients aged 18 to 60 years with computed tomography confirmed uncomplicated acute appendicitis were enrolled in the trial. Regarding the interventions, 295 patients were randomized to receive oral monotherapy with oral moxifloxacin, 400 mg per day for 7 days. 288 patients were randomized to receive intravenous antibiotics followed by oral antibiotics and they received intravenous Ertapenem, 1 g day for 2 days followed by oral Levofloxacin, 500 mg per day and metronidazole, 500 mg 3 times day for 5 days. Main outcomes and measures: the primary endpoint was treatment success, greater than or equal to 65% for both groups, defined as discharge from hospital without surgery and no recurrent appendicitis during 1-year follow-up, and to determine whether oral antibiotics alone were non-inferior to intravenous and oral antibiotics, with a margin of 6% for difference. Regarding the results, among 599 patients who were randomized, mean and standard deviation age of 36 plus or minus 12 years, 263, that is 44% women, 581, that is 99.7% were available for the 1-year follow-up. The treatment success rate at 1 year was 70.2%, one-sided 95% confidence interval, 65.8% to infinity for patients treated with oral antibiotics, and 73.8%, one-sided 95% confidence interval, 69.5% to infinity for patients treated with intravenous followed by oral antibiotics. The difference was -3.6%, one-sided 95% confidence interval, -9.7% to infinity. P-value of 0.26 for non-inferiority, with the confidence limit exceeding the non-inferiority margin. Conclusion: among adults with uncomplicated acute appendicitis, treatment with 7 days of oral Moxifloxacin compared with 2 days of intravenous Ertapenem followed by 5 days of Levofloxacin and metronidazole resulted in treatment success rates greater than 65% in both groups, but failed to demonstrate non-inferiority for treatment success of oral antibiotics compared with intravenous followed by oral antibiotics.
That's it for now. See you after 2 weeks.